Scrubs and Clogs, a podcast brought to you by the Apprentice Journal, Faculty of Medicine, University of California, where experts scrub in to bring you the very latest in surgery.
Welcome to the Scrubs and Clogs podcast brought to you by the Department of Surgery, University of California. I'm your host, Pramod Chandrasinghe. Rectal cancer is a disease that is increasing in trend world over. Especially early onset rectal cancer is considered a pandemic these days. And rectal cancer has a unique multimodal management strategy. So today we will be discussing an important aspect of the management of rectal cancer, which is neoadjuvant chemoradiotherapy. To discuss this, I have my guest here today, Dr. Sumudhu Kumarage, consultant surgeon with a special interest in colorectal surgery and head of the Department of Surgery, Faculty of Medicine at the University of California. We welcome Dr. Kumarage to the show. First of all, what is neoadjuvant chemoradiotherapy? Can you explain?
Yes, promote the now in rectal cancer, mainstay of treatment is surgery, and to improve the efficacy or the outcome of surgery, there are other modalities we use. One of these things are radiotherapy, and the other thing is chemotherapy. But still, the mainstay of treatment is surgery. So, when we use another treatment modality to improve outcome, before the surgery, it is called the neoadjuvant. When it is used after the surgery, we call it adjuvant. And in rectal cancer, it is shown there is a very clear benefit of using radiotherapy primarily and combining it with chemotherapy also improve the outcome. Mainly, it is going to reduce the local recurrence in rectal cancer.
Right. So, what is the reason behind administering neoadjuvant chemoradiotherapy? We know that there are some cancers where we go up front and operate, and then you give chemotherapy. But in rectal cancer specifically, we give this radiotherapy combined with chemo before the surgery. Can you briefly describe or explain why we do this?
Rectal cancer, when we take rectal cancer, I said sort of mainstay of treatment is surgery, and surgery and radiotherapy are the mainstay of treatment in most cancers for the local and regional control. And chemotherapy is the mainstay of systemic control. So, earlier we used surgery only in rectal cancer for the regional and local control. But rectum is a part of large bowel which is in a very closed, a very encased area called pelvis. And this is closely related to other important structures, anteriorly uterus, bladder, laterally pelvic side walls, posteriorly sacrum, and there are vessels, ureters on either side. So you can't do a wide local surgery like in sort of rest of the large bowel. So before introducing neoadjuvant treatment, the local recurrence of rectal cancer was somewhere closer to 20-25%. And it showed that surgery alone is not a very good tool for the local control of the rectal cancer. So, in order to improve the outcome of local control, we introduce radiation therapy. This is given as a short course as well as long course. In the long course radiotherapy, we use chemotherapy also in addition to radiotherapy, but the primary modality is the radiation. So radiation is another tool to sterilize or to shrink the tumor when it is involved in the rectum. This is more effective when the tumor is lower down. Now, when we come to if I explain further, when you come to lower rectum, the mesorectum, which is the fibrofatty encasement where the vessels and the lymphatics of the rectum are, which become more and more thinner when it is coming to the lower end. So during surgery, chances of spillage, chances of lymphatic damage is high when it comes to the lower rectal surgery. By giving neoadjuvant chemoradiotherapy or radiotherapy alone will reduce this thing primarily, and hence the local recurrence is reduced somewhere less than 10% nowadays.
Right, so neoadjuvant chemoradiotherapy is given because of the special anatomical arrangement of the rectum and to sterilize the mesorectum, and the primary objective, as you said, is to prevent local recurrence. And we have evidence to say that neoadjuvant chemoradiotherapy combined with total mesorectal excision reduces local recurrence significantly. So you were talking about a short course and a long course. Can you just briefly explain to us the difference between these two?
Short course radiotherapy we give over a short period of time. So the total radiation dose is the same, but it is sort of given in 5 fractions. But the long-term radiotherapy, in fact it is a chemoradiotherapy. Chemotherapy is used here to increase sensitization of radiotherapy. And this is given over roughly 1 month, but 25 fractions. So per dose fraction is less. When you give long-term chemoradiotherapy, it takes some time, it takes longer time, and further it takes some time to shrink the tumor as well. So we prefer, if a patient comes with a lower rectal cancer, to give long-term chemoradiotherapy, because when it shrinks the tumor, the surgery is technically easier, and the chances of avoiding a sphincter sacrificing surgery, or sort of chances of doing a sphincter saving surgery is more. So these are 2 additional benefits of chemoradiotherapy, because it shrinks the tumor technically easy, and sphincter saving procedures are more. But still, the most important advantage is the local recurrence is significantly low. So for these reasons, we give long-term and short-term radiotherapy. One other difference between that is short-term radiotherapy, once you give it, we have to do the surgery within the next week. So you don't have much time. But long-term chemoradiotherapy, when we give, we have an interval, minimum of 8 weeks, and roughly we do around 10-12 weeks. But some people go even beyond that. Not much data for waiting more than 12 to 14 weeks. But more you wait, it has shown that tumor regresses.
And we hear about these new modalities like 3D radiotherapy and IMRT, or intensity modulated radiotherapy, and then the previous generation used to give what is called a cobalt. So could you just briefly tell us the differences between these?
Yeah. When we understand the anatomy of the rectum, earlier also I said the rectum is in the posterior compartment of the pelvis. So there are the important structures in the anterior and the middle compartment. Middle compartment you get the uterus, vagina, and the anterior compartment you get bladder. All these are in the pelvis. So when there is a tumor in the rectum, we have to concentrate, or radiotherapy should be given only to the rectum and the mesorectum. That is the lymphatic drainage of the rectum. We don't want to give radiotherapy for the vagina, to the bladder, and also the other organs in the abdomen. So earlier the cobalt cannot be concentrated onto one point. Cobalt radiation affect rectum, true, but it does affect the bladder, uterus, vagina, and not only that, bladder also. So when we give in, and you can't sort of keep on increasing the radiation also. So if we can give the same dose only to the culprit or the tumor area and the lymphatic drainage, it has more efficacy. So intensity modulated radiotherapy is now the more sophisticated as a favored choice of oncologists, because the side effects to the other organs like radiation cystitis, radiation, small bowel radiation, not only that, the skin radiation causes a lot of morbidity. Dermatitis can be avoided, and at the same time the tumor get higher dose of radiation, and the tumor regression is more, and more effective local control can be achieved.
So basically, the newer modalities can concentrate the dose of radiotherapy to the tumor itself and prevent the collateral damage to the other organs in the pelvis. So in your clinical practice, how do you decide that a patient requires neoadjuvant chemoradiotherapy? Based on what findings do you basically decide that to send a patient for neoadjuvant therapy?
So as we have discussed so far, the main determinant main advantage of neoadjuvant chemoradiotherapy is local control, or reducing the local recurrence. So patients who are having a higher risk of developing local recurrence are the candidates who are benefited from neoadjuvant chemoradiotherapy or neoadjuvant radiotherapy. So how are we going to decide, or how are we going to how do we know that sort of this particular patient is having a higher risk of developing local recurrence? So we consider few facts. So main information is the stage of the tumor. So local and regional stage of the tumor. So if there is a big tumor, which is now, I said, lymphatics of the rectum drains along its blood vessels, which are encased by the mesorectum. So mesorectum is very bulky posteriorly, and the superior rectal artery and the inferior mesenteric vessels all go in this fibrofatty tissues posterior to the rectum. So these things, the mesorectum, when we take, it is more thick in the upper rectum and gradually become smaller in height when it comes to the lower rectum. So if you get a more bulky tumor, which is more closer to the mesorectum, the chances of spillage during surgery, chances of infiltrating the mesorectum is high. So we consider the size of the tumor as well as how much it is, how much it is closer to the mesorectum as well. And not only that, even if a bigger tumor in the upper rectum, it's far away from the mesorectum. When it comes to the lower, even the smaller tumor is very closer to the mesorectum. So this is the most important factor we consider when deciding neoadjuvant treatment. Other thing is evidence of lymph node involvement. If we had sort of already lymph nodes involved based on MRI or CT findings, or pelvic side wall deposits based on MRI, CT, we decide these are candidates. Needs more neoadjuvant control of local and regional disease.
So basically, you will decide this based on the site and the MRI findings. Right. So now you mentioned about some of the side effects of neoadjuvant radiotherapy, like cystitis, radiation enteritis, and so on. As a surgeon, when you go to operate, are there any specific difficulties that you face when you operate in a patient who has had neoadjuvant radiotherapy?
Yeah, neoadjuvant radiotherapy has some blessings as well as sort of disadvantages as well. As I said, the middle and the lower rectal tumors, it regress the tumor, makes surgeons work easier when mobilizing the lower and middle rectal tumors once given neoadjuvant radiotherapy. But at the same time, it causes sort of fibrosis, it causes vascular changes. So the wound healing is not as good as virgin tissues. So surgeons are feared of anastomotic leaks, anastomotic complications in the form of stricture, fistulas as well. So the main worry of surgeon is anastomotic failure when the patient is given neoadjuvant chemoradiotherapy. Other problems are sort of, they may have problems in the bladder, they may have problems in other small bowel due to radiation, and especially if you are doing a APR, abdominal perineal resection, radiation, dermatitis, the wound healing of the perineal wound is also compromised. So especially the healing related issues are a major concern. But at the same time, the lower and middle rectal tumors, the dissection is easier due to regression of the tumor. Overall, it has more advantages than disadvantages for the patient as well as for the surgeon.
Right. So far we've discussed the use of neoadjuvant chemoradiotherapy with the main goal is to prevent local recurrence in rectal cancer, and we have discussed the different methods of administration such as short course and long course and the differences between these two regimes, and also we've discussed the side effects and the difficulties that a surgeon faces, and we also touched on the decision making regarding neoadjuvant chemoradiotherapy based on the site and the imaging, which is mainly the MRI findings. Right. So finally, in your practice, how easy it is to convince a patient to get neoadjuvant chemoradiotherapy, because they have to wait for a period of 8 to 10 weeks after getting a long course which extends to about 5 weeks. So this is a patient with a cancer going to wait for more than 15 weeks, and as a layperson, they don't feel that their cancer is taken out. So do they comply, or are they more keen to get the surgery done? As a senior consultant who has been practicing for years, what is your experience with the patients?
Yes. A patient is disturbed from the moment they hear that they have a cancer. So basically they want to get rid of it as soon as possible. But we have to discuss not only the get rid of the cancer, but also the main objectives we are going to achieve in cancer operation. So once it is removed, one thing is he should be free of disease. The free of disease in the sense they should live without disease. Right? They may be able to live with the disease also. So for them to sort of live without the disease, they shouldn't get disease again, basically. So one problem of one way of getting disease is sort of disease in the pelvis and the rectum. We call it is a local recurrence. So local recurrence is a major problem in rectal cancer. It is not a big issue in the rest of the colon. And the other problem is metastatic disease. The disease can spread to the rest of the body. And they may later manifest in the liver, lung, or any other organ. So in the rectal cancer, we have to explain them the surgery alone will not achieve local recurrence effectively. So by giving neoadjuvant treatment, this can be reduced significantly. And local disease, and the other issue of disease is local disease, not like metastatic disease, is not a killer. You won't die of the local disease, but you will suffer for the rest of the life. So your quality of life is significantly compromised if they get local disease. So in order to achieve a better outcome of the surgery, we encourage them to have neoadjuvant treatment. So once these things are explained to them, almost all patients agree that they may undergo neoadjuvant treatment before surgery.
Right, so proper explanation about the disease and the modalities available will convince the patient to get neoadjuvant chemoradiotherapy. So I think we had a very fruitful discussion today regarding neoadjuvant chemoradiotherapy in rectal cancer. We discussed about the indications and the different administration modalities, and about the complications that radiotherapy has, and also the benefits that it gives to a patient with rectal cancer. I thank Dr. Sumudhu Kumarage for joining us for this podcast to discuss on this very important aspect of management in rectal cancer. We hope to meet you again in another podcast soon.